So we're always going to identify our patient by agency protocol. We are also going to follow state and federal regulations. We are going to abide by standard procedures or standard precautions, make sure that we're wearing gloves, hand hygiene. We are going to ensure patient safety and privacy, as well as promote good body mechanics. We're going over administering feeding through a gastric tube. I'm going to be looking at the patient's medical history or health records, for confirmation of placement of tubing. I'm also going to be looking at what kind of feeding I will be administering, the infusion rate, and the frequency of feeding. We're going to be making sure that we are looking at the expiration date of our feeding and that we are shaking it to ensure that it's mixed well. For intermittent feedings, we are going to warm our formula to room temperature. For continuous feeding, we are going to have it cool, not cold temperature. So for an open system with a bag, we are going to be taking up the lid and pouring in our formula. We are going to have approximately between 4 to 6 hours of feeding in our bag. We are going to make sure that we have it on and that we are also priming our tubing. For the open system, we are going to be using a Tomy syringe without the plunger because we're going to be putting feeding through the top of it. So we would spike our bottle. We would then hang it onto our IV pole. Usually this can hang between 24 to 48 hours. We're going to make sure that our patient's head is elevated at least 30 to 45 degrees. One of the bedside verifications that we can use is checking the gastric pH. So we're using a Lopez valve here, so we want to make sure to turn it to where we can actually gain access to those gastric contents. So we are going to be inserting and drawing back, and then we'll be checking the pH. So gastric contents are usually have a pH below 5.5. We can ask the patient to speak, as well as we can do the measurement of the tubing for NG tubes and gastronomy tubes. So this does not apply for how do you say that? Jejunostomy? Yep. There we go. So this does not apply to the jejunostomy. We can go ahead and put air in our syringe, about 15 milliliters of air, and then we can go ahead and insert it. We're going to be auscultating and listening for that whoosh sound. Okay, for subsequent feedings, and again, this is not applied to the we're going to be aspirating for gastric volume residual. And how we're going to be doing that is we're going to be placing our syringe in the tubing. We're going to be withdrawing gastric contents. If it's more than 60 milliliters, we are going to be placing it in a graduated cylinder. We'll be reinfilling the aspirate unless it's more than 150 or 200. If it is over the amount, then we would notify the provider. Jejunoscopy, the way we would check for tube placement would be instilling 30 milliliters of tap water, or we could check also the gastric pH. as well as check for the measurement of the tubing. So if we were ministrating, feeding through a pump, first thing we're going to do is we are always going to be checking our placement of our tubing. And then we are going to gather all of our supplies. We're going to grab our bag or our feeding or whatever it requires. Then we're going to take, where's it at?
You have to do this, and you want to do this. So what are you supposed to do?
Okay, then we're going to use one of those and undo our season time. Okay, so I'm going to run through this so it doesn't stop even. So we're going to go ahead and put it in on the the plastic. I gotta try it again. Okay, on the plastic or the, I don't know how you would describe it, but that would be the portion that you would be placing into the pump. And then we would connect it to, oh, no. We're going to make sure that our tubing is clamped. And then we would then come over to our tubing here, our gastric tubing. Now, right now, my Lopez valve is, the off is facing towards the tubing. Then we're going to make sure to put that in there. We would set our pump according to what was requested. And then when we are done, we are going to make sure that we are doing it and turning it the off towards the left because we want to stop flow to the side of the Lopez valve. And then we would unclamp. For using an open system, I'm going to make sure that my Lopez valve, my off, the off is facing upwards towards my tubing, so anything above the tubing is clamped off. Then we are going to be attaching our syringe. Then we would be pouring our formula to our prescribed amount through the top of the syringe. So therefore, after we're done with that and this is filled, we are going to then turn our Lopez valve over to the right. And we are not going to be holding the syringe more than 18 inches above the site. We are going to let kind of gravity control the rate of infusion. But if it is going too fast, we can always lower it down to where it produces a slower rate. So when our feeding is about halfway, we are going to then again clamp off our tubing. And then we are going to fill back up our syringe and then unclamp again. I will be showing you the closed system with the drip bottle, or the pre-filled bottle. So we have already spiked our solution and have it ready, and it is hanging on our IV bowl. We're going to, again, make sure that our Lopez valve is on the off. We would then insert the end of the tubing for the feeding. We're going to take our roller clamp and open it up to the rate of infusion that was prescribed. So for ending feeding for an infusion pump, we are going to first turn off the pump. We are then going to come over and clamp our tubing or turn off our locust valve. And then afterwards, we are going to go ahead and flush it out to the prescribed amount of water. So for the syringe, we are going to turn off our locust valve. We are going to then take our syringe out. We are going to then infuse the proper amount of water, but we need to make sure that we are turning our locust valve back in the direction to where we can infuse the water. Okay, and then for our pre-filled bottle, we are going to make sure that we are clamping it off. That we are coming over here, and we are also clamping on or closing our locust valve. And then we are going to disconnect. Then we're going to turn back on, or put our locust valve, turn it to the left again, and then we would be infusing the prescribed amount of water. For continuous feeding, we are going to be flushing them every 4 to 6 hours. Normally it's between 50 to 100 milliliters. Going to make sure also, this one has a locust valve, so we obviously can go ahead and we would turn it off. In that case, if it did not have a locust valve, we would then shut it with the little flap seal here. We're going to make sure that our patient is sitting up between 30 and 45 degrees up in bed for about an hour after feeding. We are going to ensure that we give them proper oral care. We are also going to be making sure that we are cleaning the site on a daily basis with soap and water. And we can also use a pre-cut gauze to go around the tubing.